Hey everybody, how's it going today? Hopefully you can hear me, see me. Hey Allison. No, Kate, it's been 2 weeks, I think, since we've had occasion to meet. Pretty wild. I feel like we had like 2 weeks meeting every other day practically. Or actually a couple days in a row, but yeah, here we are. Molly and Abby. So we got another three days in a row to week, and then next week too. So right. Anyway, we'll get started in a couple minutes. Hopefully you guys can see all of the lectures. And Kelly. I think I posted it, made it viewable. Yeah, it's there. So we'll start off with the endocrinology section. Yeah, nice to see you too, Aaron. I guess not see you, but it's nice that you're present with that. Cool. It was funny. I was reading a derm journal the other day. I was reading like an article out of there, and it said it was talking about the leading causes for dry skin. You know what the #1 reason for dry skin was? Any ideas? Heat? Dehydration? It was actually towels. Towels are a leading cause of dry skin, especially after showers. Too much showers. Now you guys are trying to go with the serious answers. There you go. Gets out with the appropriate response. I told that to someone. I was at the hospital yesterday. I told that to someone at work, and they thought I was being very serious. And I said, nope, just a dad joke. Say, great, now I gotta stop using towels. I gotta air dry. Like, no. For shame. He likes like Twitch pop-ups, so I can do that for bad dad jokes. And just do the shame from Game of Thrones. Hey, Kaylee. That was just my bad warm-up joke for the rest of the lecture. Ooh, that's not good, Isabel. Yikes. Which is funny because they should be super clean after you shower, wouldn't you think? But I guess not. What subjects will be on the exam? I'm planning on right now the 4 that I have posted. So the endo, nephro, urology, and surgery. I'm hoping I can get through all those. They hang near the towel. Oh, the toilet. Oh wow, yeah. Eesh. I'm glad no one tested my towel from like undergrad in the dorms. I'm sure that would have been a nightmare. Perhaps new antibiotics could have been found. Who knows? This section seems difficult. Well, you haven't even experienced it, Nicole. You have no idea how difficult it might be. Could be way worse than you think, or way better. Who knows? We'll find out. I missed you guys. It's been a while since I've had a nice interactive group of people to be working with. Don't store your toilet toothbrush near the toilet, or if you have a 3-year-old, make sure they don't put your toothbrush in the toilet. Yeah, page 2 weeks. Been quite some time, but we are here. It is 12:30 on the dot. Yeah, we find all kinds of stuff. We actually have a plastic like little magnetic fishing rod with like some little bobbers you can put in the water like for the bathtub, and we found them all on the toilet the other day. So my little 3-year-old thought that was funny. Plenty of experience. 3-year-olds do a lot of fun stuff. Anyway, we're not here to talk about 3-year-olds. We did the peds section already, I think. Put down the toilet seat before flushing. What? Just the stuff I learned from you guys. It's wonderful. Anyway, so I posted up with all your funny jokes. I'm glad you find them funny. Some people don't. Yeah, Phoebe did that. How dare she? So anyway, so as to not waste your time with inane stuff, we're here to talk about drugs, right? So if you look on the course site, you see section 3. I went ahead and put up the 4 PowerPoints, which I expect us to be able to get through for this time. So endo, nephro, urology, and surgery. That's what I'm planning for. You also find your other prescription assignment is there, which is due the 26th. So you have a whole 4 weeks to work on that. So you should have plenty of time. You have your feedback from the first assignment, so hopefully that will be, will guide you in ways to help improve for the next one. I think, I can't even remember from the assignment now. I think the biggest thing from feedback that I got just in a general sense is just to make sure you guys are focusing and on hitting every point in that rubric to make sure stuff is there. So for instance, if you write like, do this PRN, but you don't put like a frequency on there or like a once or a Q6 hours or something, it doesn't really mean anything, right? And it leaves your order up for interpretation. So it's really important to make sure everything is like very specific, very clear. And because again, you'll find, we probably alluded to this in some of like our grand rounds or something, but like nurses, especially like junior nurses, they will do whatever you write down, whatever you say, they will do it to the letter. And so you want to make sure they're very clear instructions. You have a lot of those more like senior nurses who'll be able to like save yourselves, if they see something that looks wrong. But a lot of people that are new, they may just say, okay, well, this must be normal. The PA wrote it. I'm going to do it. So that's why I like to make sure you guys are very clear and specific now. But anyway, let us continue on. How many people I got in here? Only 13? Oh no, I'm up to 43. That's great. Oh, I'm sorry to hear that, Kate. ARCS assignment due in a nephro exam. Well, you can do the ARCS assignment early. I would encourage that. That way it'll be done a little bit sooner. Nevertheless, have to worry about it. I can't do anything about the nephro exam, though. But anyway, so let's talk about diabetes. Let's talk about glucose homeostasis and some meds for that. Pretty cool stuff. I really like diabetes. I think it's really interesting disease states to talk about. Oh, I'm turning 30. Oh boy, that's where everything starts going downhill. I find maybe it's just me, but as a year I had my first daughter, and everything started breaking down physically. But regardless, so glucose very important for energy production, right? And so we're going to see, happy birthday to both of you guys when that pops up. But, we know glucose is really important as a precursor. It donates a lot of carbons and things like that to help out with production for like amino acids, nucleic acids, all that good stuff. And, we have some base requirements, about 190 milligrams a day, just in order to keep your body like alive from like a brain perspective, since it's pretty limited in terms of what the brain can use for energy, as opposed to, the rest of your body can be using, fats and proteins and stuff like that for energy. The brain's pretty much well stuck with glucose. With diabetes, we know this to be a metabolic syndrome characterized by these elevated glucose levels, right? Big problems, and I'm sure you've discussed this elsewhere with maybe Professor Kaplan, but talking about things like cardiovascular disease seen with this, neuropathies, nephropathies, retinopathies, all kinds of issues that we run into here. And so we don't want to cause that to be an issue. So we'll talk about ways you can manage diabetes for these patients. Hopefully you can prevent it in a lot of cases. However, it may not be the case. I'm not going to go real deep into the guidelines in terms of like what your goals and things like that are, because you'll get that in other courses. But I mainly want to talk about the drugs that we use, how we use them, and all of that. Certainly diagnosis, can be made based off of history with some follow-up confirmatory testing. So things like random glucose levels, fasting glucose levels, A1Cs, all of that good stuff can be indicative of diabetes. And of course, you've covered these elsewhere, so I don't want to belabor the points there. We'll mainly focus on therapy between, say, type 1 diabetes and then type 2. Certainly there are some other little varieties in there. We talked a little bit about gestational diabetes. That talk then will make more sense now once we have some context in terms of how we use insulin and whatnot. And certainly be nice if you could catch people early when they have impaired fasting glucose before they really reach having a true blue diabetes diagnosis and have long-term complications from there, obviously. So typically when you're looking at patients, like why they die with diabetes for type 1 patients is typically due to the renal failure that they can develop and then the morbidities that happen on top of that. Type 2 is more often certainly the macrovascular complication like cardiac disease and things like that. In terms of risk factors, type 1, typically we don't know fully why. It could be related to genetic issues, could be related to viruses, who knows. Type 2 more so you're going to see as a result of like lifestyle choices, obesity, ethnicity, which obviously is not a lifestyle choice, but things like that. There's a genetic component for sure, but then there's also going to be a lot of lifestyle things that we can focus on as well. Certainly in terms of how we regulate this, we know that it is our pancreas that helps out with this quite a bit. And we're going to talk a lot about the interplay between glucagon and insulin and how those two sort of play a role together. We'll talk about the liver quite a bit in terms of regulating glycogen and producing new glucose or storing it, or the case may be. Certainly know your beta cells, really important for releasing insulin, helping for fuel storage, promotes growth. It's an anabolic hormone. I've never really thought about like insulin being like an anabolic like hormone until I thought about like bodybuilders using it, but that's absolutely what it is. Whereas glucagon's more about mobilizing storage to produce new glucose. So glycogenolysis, gluconeogenesis, all that good stuff. Not going to really talk about somatostatin so much, but although we do know it has some inhibitory actions on things like insulin, but really it shouldn't come up here too often. And you can see kind of what happens to these patients over time with type 2 diabetes, especially how they're going to be basically wearing the pancreas out. They've had such high basal levels of glucose for so long, it's just wear and tear on the pancreas, at least for type 2. Obviously for type 1, it's more of an autoimmune issue here. But what you're going to find is that with type 2 patients, one, they're very insulin resistant, and the peripheral tissues like the muscle and the fat and whatnot, but especially within the pancreas, you're going to find that their insulin production is going to decrease over time. And you're also going to find that they have really sort of inappropriate levels of glucagon, which is not good because that's also dragging their glucose levels higher as a result of its effect on the liver, as we'll see. And so a lot of our drugs may not work specifically just to provide more insulin, but it may have effects in terms of helping to decrease glucagon. It may have abilities to help out with sensitizing our cells to be more responsive to the insulin that patient already has. And we'll see some ways we can do that with various drug classes and things like that. So, we can see sticky board if I need it. So when you're looking at beta cell function in type 2 diabetes, you can see here like we have quite a bit of reserve, and so it's not until quite you've got some real damage going on by the time patients will get an actual diagnosis, mainly because of the ability for the pancreas to sort of pick up the slack for quite some time. And so by the time a patient gets a type 2 diabetes diagnosis, like they're kind of behind the 8 ball in more than a few ways, as we'll see there. But let's focus on type 1 first, because I want to talk about insulin more specifically and all the different formulations we have there, and then we'll get more into type 2 diabetes, because for type 1 diabetes, it's like you just have insulin. That's pretty much the way we treat that, versus with type 2, we have a whole plethora of different modalities we can select from. With type 1 diabetes, we're seeing again with this sort of selective loss of beta cells. It's most of the time an autoimmune condition, and really kind of interesting because you can see sort of if especially a younger patient with type 1 diabetes, you may ask them about other autoimmune conditions, and it's not uncommon for them to have issues of like Crohn's, or they have other issues of an autoimmune nature to go along with their diabetes. It's not just selective for the beta cells in some cases, as you'll see there. But anyway, the insulin itself, we know this is it actually has a prohormone version called proinsulin that gets released and then can be cleaved. Basically, these two sulfide bonds, and then that way you'll have the C-peptide, and then you'll have insulin proper, which is able to go and interact with the various tissues and whatnot. I will demonstrate what this looks like, and again, I don't care that necessarily the amino acid sequencing here, but this will be relevant in just a few minutes when we talk about various types of insulin that we have and what kind of differentiates one from another. But you can see here, this is what proinsulin would look like when we have the actual insulin itself. It's just basically going to be this cleaved portion, this white portion here, whereas the C-peptide will also be circulating. You can actually measure that as well, and that may be useful in some clinical circumstances to see kind of what their insulin's doing, by also looking at the C-peptide levels as well to see how much they're really producing or not. So again, they should be released in equal amounts because it's kind of a 1-to-1 ratio there. We don't know really what C-peptide, if it serves any function. But as I mentioned, it can serve as that index of insulin secretion. So, potentially if I had a patient who presented, let's say for instance, like a suspected tox case, and I had someone present with hypoglycemia, and I wasn't sure if it was because of, say, they injected themselves with insulin, or is because they took something that's causing too much insulin to be released from their own pancreas. You could look at something like C-peptide, and if it's high, then I would know, okay, well, that's their own pancreas doing that, versus something like an exogenous source, which would have no C-peptide. So this is an example. You can use that as sort of that index there. And when you're looking at how we actually process insulin, a lot of it gets metabolized through the liver, but some does go through the kidney. That's important because you'll find that while it has a relatively short half-life, you can find patients with renal insufficiency, especially like acute renal insufficiency, end up developing hypoglycemia as a result of them being unable to clear that insulin and it's sticking around for longer, thus driving their glucose lower. So that's something you might see sometimes in, like, critically ill patients that develop renal failure. All of a sudden they get hypoglycemic and you're like, well, what's going on? It could be related to that extended half-life of their insulin there. So what specifically happens in terms of causing the actual insulin to release? Like, what is that process there? Well, basically, the pancreas will be exposed to elevated levels of glucose. Let's say you just had a nice meal or something. Your glucose is going to be elevated, and that will bind to a GLUT2 transporter on the beta cells. There's a variety of different GLUT transporters. I'm not going to get really specific about which ones are where. Just know that there's a variety of them. GLUT2 tends to be expressed on the pancreas. And so basically it'll bind to that on the beta cells. It'll get internalized from there, and then it gets converted over into ATP via the citric acid cycle, right? And so, of course, we're not going to go all through that because that would be just very laborious and unnecessary. But it gets converted to ATP just like glucose does elsewhere. What's interesting about that is that elevated levels of ATP then close these potassium-dependent channels. Now, normally, potassium in the inside of the cell is in a higher concentration than the outside. When you close those channels, it prevents potassium from flowing out of the cell, right? When that happens, that increases the electric potential, that depolarizes the cell, and allows for calcium now to flow in through some voltage-gated channels. The potential rises up, voltage-gated channels open, and calcium flows in. That calcium then serves as a sort of catalyst to cause exocytosis of these insulin vesicles to fuse with the cell and then to release it out. And then you'll actually find this is actually a place where the sulfonylureas can do this specifically by just actually closing these potassium channels on their own. But we'll talk about those drug classes in just a little bit. If that doesn't make sense, here's a sort of pictorial example, which may similarly confuse you, but I hope it will be more clear, is once the glucose gets taken up, gets metabolized to ATP, closes these channels. This causes the depolarization because now you have more positives on the inside. That then allows these calcium to flow in and causes the exocytosis of insulin. Thus, you have more insulin floating around, can now interact with your peripheral tissues and drive down glucose levels, right? So that's how your body knows to release more insulin is when those glucose levels are high. More of your beta cells are taking that up. Because you'll find you have a basal amount of insulin you should be releasing kind of throughout the day. And then you'll have spikes of insulin that get released in response to elevated glucose levels. And that'll make sense when you talk about insulin pumps and things like that coming up. So anyway, so then when you get out to peripheral tissues, you have things like the GLUT4 transporter responding to this. This will then, that's actually a tyrosine kinase receptor there, but it causes more glucose, basically transporters to be taken up to the top of the cell, basically, to be able to suck in more glucose where it can be stored or be utilized for energy. Paige says, this is clearer than the wrong class and time to eat my leftover cheesecake, which may stimulate your own insulin release. Who knows, right? This is a good time to start snacking because we can actually see the process happen in real time, right? We can get some AccuChecks next to you and do maybe some Q5-minute blood sugar readings and see what's going on. I would never experiment with my own students. That would be wrong, especially not after that last time. You can't do it anymore. Anyway, you can imagine here in the insulin receptor binding to this tyrosine kinase receptor here cause lots of downstream things to happen, right? This is this regulates growth of cells like muscle tissue and things like that. But the big thing that we're going to focus on here is it causes this translocation of glucose transporters up to the cell surface, which then will suck in glucose, convert it over into ATP, or maybe stored as glycogen, whatever the case may be. It goes down all through those pathways, okay? But that's where the glucose goes. It's not like it just disappears. It just gets shuttled into the cells, right? Anyway, so looking at here, you can see the different transporters where they lie. Again, I'm not too worried about you memorizing this here. You may need it for other classes, but for my purposes, I just care that you know they are glucose transporters. This is what they do essentially: is they take in glucose into the cell for something, right? Whether it's producing, releasing insulin, whatever the case may be, right? Yeah, the path, it gets really complicated. Like, insulin's like a really complicated hormone when you think about it in terms of its actions just throughout the body, which is why we're going to be focusing on its actions so much moving forward in terms of the various effects that it has, and how we can sort of help to regulate that. Some of the things I want to focus on here that I do think are important in terms of what insulin does to various tissues, right? I know I'm sorry to give you the biochem PTSD. I remember doing this in pharmacy school. Actually, biochem was not a prereq for me to get into pharmacy school. So the first time I had it was at like the doctorate level, and that was pretty intense, I will tell you. And I remember having to come up with really inane acronyms to remember the whole TCA cycle and be able to draw that on a test, and that was not great. But anyway, so look at the effects of insulin at the tissue. This is what I do care about, is you're going to see that it helps to stimulate one in the liver. It's going to be stimulating you to uptake glucose into the liver and to hold on to that as glycogen, because that's a good energy storage sort of currency there. It'll also help to do things like convert to fatty acids, some like glucose to fatty acids, adipose tissue, things like that. Oh, it's funny you did better in the grad. I think it's because it makes it more pertinent to like what you're focusing on, so maybe that helps. But on the other hand, though, you'll find that insulin should be inhibiting glycogenolysis and gluconeogenesis. That makes sense because if you're releasing a lot of insulin, you're in a more of a glucose storage sort of mode than you are in a glucose generating sort of mode. You'll also see that it will inhibit those the conversion of fatty acids into ketones, because we just don't need that process to occur because we have plenty of glucose, right? If we're releasing insulin, we should be okay. On the skeletal muscle, you'll also see that you can store some up as glycogen. You'll also have cause this to help with the shuttling in of amino acids as protein. That's why, like for instance, I think with like some like bodybuilding routines, like you'll see them have big like carbohydrate and protein intake after a workout, because that'll help to shuttle in all the insulin you're releasing after that carbohydrate intake, shuttles all those amino acids into the muscle to help make bigger muscles, basically, right? And it also will inhibit that process, the degradation of the amino acids, because you don't need to, right? In an anabolic sort of state. And then in the adipose tissue, this is one of the big things you see is that I remember growing up, they always said, oh, let's go with low fat stuff because fat makes you fat. It's not really. It's more like carbohydrates that really do it, more so than anything. At least a relative sense. But here you can see that it helps the storage of fatty acids as triglycerides, and then helps to prevent the conversion of those triglycerides to fatty acids. So again, you can see how it will inhibit the opposite process that it's stimulating there, which should make some sense to you, I think. So this is an important slide because this kind of shows you what sort of your insulin release looks like as compared to your glucose levels. And this should make some pretty intuitive sense, I think, for most of you. Again, you should have some, if you consider going throughout your through your day here, you'll see that there's some basal amount of glucose in your body, which is good because you kind of want some basal glucose because your brain needs that to function. If this was like 0, then you'd likely be dead, which is not great. But anyway, you can see that you'll have a basal level of glucose, and then you'll have these spikes up of glucose usually around mealtime, whether it's your breakfast where you had your, your Pop-Tarts or something, and then your lunch, maybe you had a little salad, and then at supper where you had maybe some potatoes and rice, I don't know, whatever you're going to have, right? Quinoa, perhaps. But you'll see that the insulin should spike up in response to that as you go throughout the day. So you have a spike in glucose, you get a spike in insulin, just like we were looking at with those beta cells in its response to glucose uptake in levels of high glucose, right? Because in response to a meal. So when looking at, and again, when you're looking at this, the reason why I like to draw attention to it is because it does seem pretty intuitive, I think, when you're thinking about it, how your body's responding. The regimens of insulin that we use for people who can't produce their own, so primarily type 1 diabetic patients, we need to mimic this. We need to get this as close as we can, while also considering sort of the challenges of giving insulin for these patients here in terms of like lifestyle and things like that. We want to get as close as we can because that's going to mimic what the body would normally do. And again, we have ways to do this sort of automatically almost to a degree, but I think this technology is going to be way better in the future when we can have like, artificial pancreases that we can just put into a patient and they don't have to think about it any. But we're not quite there yet. So anyway, getting into the insulin itself, we have about 17 different formulations, which I'll show you some examples of. And how they differ is going to be the time to onset of activity. We're going to focus on the short-acting versus medium versus long-acting insulins. We'll talk about the duration of action, and then also some of the solubility characteristics, which will have some effect on its duration of action, as we'll see as well. We'll also see that by changing different portions of the insulin, you can change the pharmacokinetic profile, right? So for instance, we could put zinc into the concentration, or into various concentrations of zinc into the product, and that makes it last longer. We could add things like protamine to it and make it last longer. We can do things like changing the amino acid sequence, and that can change how quickly or how long it's going to work for. So lots of different things we can do here. So just an example, here's what the pro-insulin would look like. You can see the C-peptide chain here. When it's cleaved, again, it would just be these two chains that are attached by these disulfide bridges here. So was interesting is that for a long time, we knew these patients had diabetes, they couldn't produce their own insulin, and a lot of people just died of DKA back in the day before we had good sources of insulin. And so in the meantime, what they did was actually try to use animal sources. So for instance, here you could see what bovine insulin, you just basically do a couple of replacements of the amino acid sequence, and you have bovine insulin. That's what cows produce, and it's pretty close to what humans make. So it says, well, let's just give them cow insulin, and then we should be okay. And that worked for a time, right? We also use porcine insulin here. You can see what this would look like. So pig insulin. Obviously, this might be a problem for some people who have certain, religious beliefs. They don't want to receive products that come from an animal, potentially, right? You can imagine that could be an issue. Also, problems when changing the amino acid sequence. Now, the body might find that to be foreign and may want to have anaphylaxis to that, right? So, but that worked for a while. It was better than dying of DKA, I guess, in some cases. And so since then, we've come up with more sort of sophisticated ways to produce this ourselves. So for instance, here we have insulin Lispro, which I'll talk about how that works. But basically, it takes this proline and lysine and just flips it around. And all of a sudden, it has different characteristics than what normal human insulin has. And when I say normal insulin, I'm talking about what you produce, what a natural human would be producing in terms of insulin. Here's insulin aspart. It just pops into aspart instead of a proline there. Insulin glargine, all of that. So we will look at some different ways we can do this in order to get different characteristics in terms of how they work. Again, I'm not going to ask you which amino acids have been changed and what they're changed to. I don't care. I don't know that I could probably do that under testing purposes, but I do care that you know how they work differently than one another and being able to identify a short-acting one versus a medium versus a long-acting. And it should be fairly straightforward when we get into it. Not a ton of rote memorization, as you'll see. As I mentioned, we used to use beef and pork variety of insulin there, but it was more antigenic. You can get pork insulin still. It's like a special order. I've never seen it used, but apparently you can still get it on occasion there. Nowadays, though, we actually have human recombinant forms that we've engineered things like E. coli or yeast to actually produce for us. So for instance, if you have like the Lilly products, so Lilly Pharmaceuticals, that was not the genesis for my kid's name. She only has one L in her name, although that would have been probably smart for two pharmacists to do, but that's where you get Humulin, right? So that line of, or that brand of insulins come from E. coli versus like Baker's yeast, or where you get the Novo Nordisk products like Novolin, right? So those are the kind of the differences you'll see there. And honestly, like when you're working, like your hospital or wherever you work, probably it will just have a formulary where they have one line or the other. So for instance, like our hospital has Humulin products. That's just what we carry. And then some patients will come in on Novolin. We'll either use their product or we'll switch them over. They work very similar to one another for the most part. We'll look at a few different types. So, and a lot of this has to do with how quickly they act. So it's usually very fast acting and short acting together, or it's very long acting and very slow acting. And so we'll look at some of the varieties there, and I'll show you some graphs of what that looks like as well. So we'll have the very ultra short acting insulins here. So you'll see insulin Lispro, insulin aspart, insulin glulicine. It's always preceded by the insulin. We'll have short acting, which is just regular insulin, which is what you produce. So if I hear regular insulin, normal insulin, that's what I'm talking about. We'll have the intermediate acting, or NPH. Not stand for Neil Patrick Harris, but it has to do with the protamine that they include there. Long acting, which is the ultra lente form. This one's not used as commonly, as we'll see. And then the ultra long acting, including insulin glargine, detamir, and degludec. These are very common. You're going to see these used quite a bit, as we'll see. And then we have the inhaled form, which is not quite as common, but you can see we'll see some of the potential benefits of using inhaled, especially for people who might be a little bit phobic of needles, but it's called a Freza there. So anyway, you can kind of see the differences in terms of the peak effects of these drugs here and how long they work for. So if you were to look at something like insulin aspart, which we said was a very ultra rapid acting, you would see this peak effect very quickly. Now, what sort of situation would this be good for? Well, perhaps dealing with a big bolus of glucose, like perhaps after you eat a meal. So you'll find that the short acting, the ultra short acting, both can be used for like mealtime correction of insulin, right? There or mealtime replacement for insulin that the patient may not be able to produce themselves. The more long-acting formulations like NPH, insulin detamine, or glargine, those are they don't really have a big peak effect, really, especially the insulin detamine and glargine, which you're going to be using more often. They really don't have a big peak effect. So they're not really good for like mealtime purposes, but what they do is that they help to replace that basal amount of insulin that your body should be releasing on a typical minute-to-minute basis because you're dealing with normal levels of glucose in the body, right? You're always producing some amount of insulin, just may not be a lot as compared to like, meal times or something. So it's kind of important to kind of understand the differences in terms of how these are working, how long they're working for, to understand how we're using them and how we might be using them differently from one situation to another, which we'll get into. Conventionally, because these are proteins, you have to inject them. And so this is typically done as a sub-Q injection. You may find insulin drips or they're being done IV, but far and away most commonly a sub-Q. This is either where you can draw it up into a syringe itself and inject it subcutaneously. You will have pins, like actually pre-filled syringe pens that you can dial in a dose to and basically attach a needle and inject it that way. There are subcutaneous infusions, which I think these are really cool. I think these are really neat to see patients being able to develop a lot of autonomy, being able to use continuous sub-Q infusions. And then even now we have sort of a dry powder inhaled form or Freza. I've never seen this used for any of my patients, but it could be as an alternative for people who maybe don't like to inject things. So this is really neat with the insulin pumps. You can see here, this is the first insulin pump that's ever was produced. I think this thing looks really wild. It's like almost having like a proton pack on your back if you're into Ghostbusters or something. You might imagine this would probably be liable to break down and probably be a little bit conspicuous, I would say, as opposed to if you have the ones nowadays, and I don't want to age myself and say it looks kind of like a beeper because I don't know that most of you know what beepers are, but it's quite small. You can see how it fits right there. Not much bigger than anything you carry in your pocket for instance, but there's a sub-Q implanted cannula here that will allow for insulin to be infused either as a bolus or as a continuous drip. You'll see kind of both there. Matt's asking, do the pen injector use the same needle over and over? If so, that seems like a potential for infection reusing a needle. Never, ever, 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 ever use needles. And that's one of the big expenses you'll find with patients with diabetes is they have to buy supplies to go with all of their insulin, right? Not only is insulin expensive, but you have to buy testing strips and you have to buy the needles that go along with that, the syringes if you have to drop your own doses. And so that's a huge thing. So yeah, you always have to use new needles. Those needles get dull after a while too, and it would just be very painful and to inject. I would not recommend that ever if you can avoid doing so. I'm gonna say it reminds you of Fallout a little bit. I could see that. I could see a little bit of Fallout there. Andrew, I feel sorry for you. You had a pager in high school. I had a pager during fellowship, and that was in 2010 to 2012. But that was because in parts of the hospital, like cell signal didn't reach anywhere, but pagers were still like super reliable. So you'll still see pagers being used occasionally, like in certain hospitals, especially older places. Someone said, just a quick example, you would have something like Detamir for throughout the day, then maybe quick-acting insulin like Lispro after a meal. Nailed it right on the head there. I'll show you some graphs of how we can use different types of insulin in combination, just to give you some ideas of how that works there. But yeah, that's absolutely true. That's how we would do that. So this is a handy set of slides here to know the different types of insulin and kind of where they fit in terms of long acting versus rapid acting. I don't care that you know the administration options here so much. This is just for sort of your edification. You can see how like the pens come in a 3L amount, and so that actually has about 300 units of insulin in there. Insulin's dosed in units, not like milligrams or micrograms. And so they would reuse the same pin, but they have a needle tip that they would change every time. It's like a little screw-on needle, and they would change that out every single time they use those pins there. Or they just get the vials that they could draw out of if they needed to. We'll talk about some other techniques and things like that. We'll see in just a little bit. So anyway, so the rapid acting insulin, these are good for like mealtime replacement, or if you needed like a quick adjustment. So maybe if you like checked a patient's glucose and it was like 300, you could give them a fast acting insulin to help correct that in right now, because it is very fast acting, has that good peak effect there. So you have Humalog, Novolog, and then Apidra. So be able to identify that Lispro, Aspart, and Glulisine are going to be your ultra rapid acting insulins, right? Actually, glulisine is the newest one out of this bunch here. And normally you would take these, maybe like 10-15 minutes before your meal, so that way it gives it time to absorb sub-Q, and you can deal with that glucose as it comes in. You could actually take a Pedra with like the first dose of your meal, because it works so quickly, which is kind of neat. Then you have your short-acting insulins. This is going to be your regular insulin. So Humulin R, Novolin R. If you see the R, that means it's a regular insulin. That means it works just like the insulin that you produce yourself, right? If you ever see U100, that stands for the concentration. That means it has 100 units per ml. That's the standard, is 100 units per ml. But you may find some patients require much higher concentrations, like U500, U300, because the doses that they require are so high that the amount you're having to inject becomes sort of not really feasible. So like if you have like really poorly controlled type 2 diabetic patients, I've seen them require like U500, just like gobstopping amounts of insulin, because they're so resistant to it. Typical like type 1 patient, they don't have a ton of insulin resistance because it's just their problem is they don't produce it. So most of the time you default to U100. Just be very, very careful if you ever mix up and get a different concentration, because it's very easy to overdose and kill somebody with this stuff. So like I'm talking about dangerous drugs. This is one of them. It's like a really high alert, don't screw this up kind of drug, because it's very easy to kill someone, and you need to know about the safety precautions and things like that. Otherwise you can get yourself into trouble, right? It's easy to fix if they get hypoglycemic, but you got to recognize it, right? So sometimes you'll have the patient laying in bed in their room, and they look asleep, but really they're hypoglycemic and going into a coma, right? Next thing you know, they're seizing. But so you can be really, really careful with insulin. It's very easy to screw this stuff up. So not scary, but just make sure you have a proper respect for the drugs that you're using for your patients there. Kind of like a gun, right? Might have their purposes, maybe getting food or something like that, but they can be very dangerous if not used properly. So I'll leave it at that. Then you have your long-acting insulin. Charles Cullen started off killing his patients with injecting insulin to IV NS bags. That would be one way to do it. I would not recommend killing your patients, but yeah, that would be certainly a way to do it. And again, you could check that. Actually, interestingly enough, you could see if someone was trying to murder somebody with insulin, because you could check their C-peptide levels and it would be low, because this stuff doesn't include C-peptide. So that would be one way, like maybe the medical examiner could identify if this was foul play happening here. But anyway, looking here at the intermediate acting insulins, this is where you have the NPH insulin, Neil Patrick Harris insulin, Humulin N, and Novolin N. So if you see N, that is the intermediate acting. To be honest, I don't see a ton of intermediate acting insulin being used all that often. More often than not, it's regular, rapid acting, and then the long acting insulins. So you still may see it used occasionally, just depends on the provider and the patient, kind of what they're on. The long-acting ones you're going to see used all the time, and this is going to be predominantly what you're going to find a lot of type 2 patients being put on, if they are put on insulin, will probably be on a basal insulin, and this includes Glargine, Detamir, and then Degludec. These are ones you're doing one time a day typically, because they provide like 24 hours worth of coverage, whereas like the NPH is like Q12 hour sort of dosing there, right? And the murders Mrs. Peacock in the library with the insulin, yes. It was Colonel Mustard in the I don't know, ossuary with the TCAs, perhaps, right? All kinds of dangerous drugs. You may even find there's mixtures of insulin here. So for instance, here's one where you see like a Humalog mix 75-25 contains some of that NPH insulin, that protamine insulin plus Lispro, right? So that way you get sort of a quick acting plus a longer acting all in the same shot. So that's kind of nice, because it helps with compliance, because the fewer shots you have to give, the better off it is for the patient. There's a kind of a balance between how tight of glucose control you can have versus how many shots you have to get throughout the day. I could give a patient a shot every single hour throughout the day, and they'd have extremely tight glucose control, but they're probably going to be pretty upset at having to get shot every hour, right? Or get a shot. I shouldn't say shot. That would be pretty upsetting if I got shot every hour too. But Regardless, you can give fewer shots, but they typically have less tight control over the glucose, unless you're doing like a sub-Q infusion, which we'll talk about some examples of that in just a little bit. As I mentioned, you can find different concentrations, like U500. Just be very careful. This is like playing with fire. Make sure everyone knows that you're using non-standard insulin concentrations, because again, if you screw it up, you're either giving maybe a third of the dose you're supposed to, or like 3 times the dose, 5 times the dose, and that is a quick way to kill somebody. And then here's the my favorite generic name ever, the Technosphere insulin. If we talk about something sounding sci-fi or Fallout, that would be one of them. And again, that would be more of a fast-acting mealtime sort of insulin there. Okay, so again, looking at these, you can kind of compare and contrast how quick their onset is versus how they're working in terms of their peak effect, their duration, etc. I'm not going to quiz you on specific numbers here necessarily. What I am going to ask you to know is be able to identify which ones are good for which situations. Like for mealtime coverage, rapid acting and regular, pretty good, right? You can get away with that for more short-term corrections of glucose. For intermediate to long acting, those are better for basal insulin replacement, right? So that's something you'd be taking in the morning, like NPH be taking in the morning at lunchtime probably, and that will provide you coverage throughout the day. So that's kind of what I'm looking for you guys to know. Someone said, do you need to know the components of the premix, combo, or concentration? No, if I provide you like an example, if I say like, what do you need to worry about with U500 insulin? Like you should be able to identify that, but I won't expect you to remember what concentrations they come in or anything. That would be sort of ridiculous. I wouldn't expect anyone to get those features out of there. Again, I'm caring more about how you're using the drugs, making sure you're using appropriate choices of picking one versus another. All of that is kind of the stuff I want you to know. So I mentioned the hypoglycemia obviously is the biggest complication here. Certainly you're going to find weight gain associated with this, which makes sense because this is an anabolic hormone. That glucose should be getting shuttled into the cells, into the fat tissue. Yeah, the patient's going to put on weight. That's a known thing. And again, typically like type 1 patients are usually fairly skinny because they can't shuttle a lot of that glucose into their cells due to that deficiency, right? So it makes sense that they put on some weight when using insulin. But again, we'll talk about ways to treat hypoglycemia. You'll see it's pretty straightforward. There's only 2 things we use for that, and one of them you can probably guess what it is already. Some other complications here include some immunopathology. So you can see things like insulin allergies, like a true anaphylactic allergy that can happen here. It's not super common, but it can occur. And then sometimes they can actually end up developing an insulin resistance, like an IgG sort of thing, where your body will start to neutralize the insulin and make it less effective. So sometimes you may need, just almost like how we saw with like patients with rheumatoid arthritis, they can get resistant to like infliximab because their body develops antibodies against it. Not causing anaphylaxis, just neutralizing the antibody. You can see the same thing sort of happening here. It may require switching over to a different product potentially to get around that. And then, you can see some issues if you're injecting cold insulin. Most of the time, this should be stored at room temperature. I'm sorry, not room temperature, at cold temperature, usually in the fridge, because these are proteins. They degrade over time. And so storage is really important. Now, normally these insulins are good out of the fridge for like 28 days, which is usually how long like a vial or a pen will last you. So typically you can get away with that. But otherwise, they should be stored in the fridge. And so injecting that cold insulin can cause some pain, some vasodilation. So that would be one thing. They can just kind of gently roll it in their hands to warm it up some. That can help. Certainly make sure they don't keep it like in their car in the middle of a Florida summer, because all that protein is going to denature. It's going to be no good. It's not going to work anymore, right? And then typically these patients are injecting usually into the abdomen, just because it kind of makes sense mechanically. Just it's easier to do that. Just make sure they rotate around sites, otherwise they can develop a lipodystrophy. So just be aware of that. Someone says, how would you treat a severe type 1 diabetic if they're allergic to insulin? Boy, I hope that wouldn't happen. That'd be sad. I'd probably use something like a regular insulin, because chances are they would be unlikely to have a true anaphylactic reaction to that. Could there be some contaminants in the product, or maybe not contaminants necessarily, but could there be some adjuvants in the insulin product that could be causing a problem? Potentially. Like you may find some people like protamine allergy, so like an NPH wouldn't be good, but regular insulin, the amino acid sequence is what you produce, so that one should be okay for the most part. But if they have like a problem with like humulin, I'd probably switch them over to like Novolin, probably, and see if that would be if that would change anything, because they might be having a reaction to something else in the product there. A beta cell transplant, I don't know anything about that. Can they do that at all? Not that I'm aware of, but again, what I'm not aware of could probably fill a whole library and then some. I'm not aware if the site of injection really makes a difference in terms of absorption rates. Um, I think it's pretty similar regardless. And again, some of them are meant to absorb really slow. So especially like the glargine and detamere, they're kind of designed to slowly absorb into the bloodstream because of the fact that it is supposed to be lasting throughout the day. I wouldn't recommend intraocular. That'd probably lead to some infection risk, possibly some vision loss, which those patients worry about vision loss anyway. So I don't know if I'd recommend that. I don't know, needles in the eyes always kind of wig me out a little bit. Um, Anyway, so some things that can decrease the hypoglycemic effects of insulin. So what are some things that kind of pharmacokinetically make insulin less effective? Because if you find patients are still hyperglycemic and they come in, or you'll see this happen a lot too. So you have a patient who's on insulin, and they come in and they get their glucose checked in the office, and it's like totally normal. You're like, great, good job. Then you check their A1C, and it's like 9 or something, like 9%. They just took their insulin like that day before coming in to see. That wasn't they're actually being compliant. But in some cases, it could be related to other medications, which may be causing some hyperglycemic effects that are sort of butting heads with the insulin, right? So, for example, things like corticosteroids. We know steroids are going to be increasing glucose. We've talked about that a gazillion times already. Well, that's going to directly counter the effects of insulin, right? So it may make sense you have to adjust your insulin while they're on steroids. A lot of sympathomimetic products, so things that mimic the sympathetic nervous system, will also combat the effects of insulin as well, which makes sense because if you're in a fight or flight response, you're going to be activating all those beta receptors on the liver and producing gluconeogenesis, right? Producing new glucose. So things like epinephrine, things like pseudoephedrine, dobutamine, they can combat those effects and cause the glucose to rise, right? Some other things you might not think about include things like thyroid hormone, oral contraceptives, thiazides, little things like that you may just want to consider when trying to figure out, okay, well, why is this insulin not working like I expect it to? Do we need to do something in order to, adjust this, or is it a medication thing we may be able to get around, right? So little things like that to consider. Okay, some things which increase the hypoglycemic effect of insulin, things that make the insulin work better, which may be again, a double-edged sword. You don't want it to work too well because if that glucose comes back and it's like 30, you're kind of in trouble at that point. But things like anabolic steroids, so if they're on like performance-enhancing drugs, like certain testosterone-like products, if they were on beta blockers, if they were drinking alcohol, all of that can lead to the hypoglycemia risk being higher, and that can be a problem. I recall, like when I was in undergrad, I was a very nerdy, very naive undergrad person. I remember I had someone in my dorm area who was a type 1 diabetic patient. I remember like walking in and seeing her like drinking. I was just like, should you be drinking? And she goes, I don't think so, and just threw back a shot. And I was just like, oh, this is a bad scene. We should probably leave. I was not very popular. That continues. But regardless, alcohol can increase that hypoglycemic effect. So you got to be really careful with that if they're going to be mixing and matching these drugs here. Anyway, so what are our indications for insulin? Typically, all newly diagnosed type 1 patients, that's going to be at a baseline. They're all going to require, because again, their problem is they don't produce insulin themselves. We mentioned for patients who have pre-existing type 2 diabetes or develop gestational diabetes, these are insulin's kind of like the most natural, safest way to go. Sorry, I think I have a sneeze coming. I'm trying to like not sneeze right into your ears. Of course, I thought too hard about it. Now it goes away. But anyway, so women who develop gestational diabetes, it's a very natural way to replace some extra insulin that they could require there, so it's relatively safe from that standpoint. And then if you have patients with type 2 diabetes who are not controlled by diet, exercise, and oral medications alone, typically for type 2, if you can get away with oral meds, that's better from a compliance standpoint. It can be a challenge again, for them to be compliant anyway, because especially if they're having trouble with their diet and exercise, it may be difficult for them also to be compliant with having to inject themselves because it's uncomfortable. It may put on some weight, things like that. So if we can avoid that, that's great, but that's still an indication. And then some other sort of like emergent cases, things like diabetic ketoacidosis, which may be how you discover someone is a type 1 diabetic. For type 2 patients who develop really severe hyperglycemia, that it may develop this hyperglycemic hyperosmolar non-ketotic syndrome, which is, again, you'll find if you ever want to see the highest glucose levels ever, that's probably those patients there. They'll be up in like, 600-700 range. And then actually hyperkalemia is another thing we can do here as well. We'll find that by giving insulin and glucose, you can really drive potassium into the cells And I'll get into more of that when we talk about hyperkalemia from like the emergency medicine standpoint. So I'll talk about that there. So insulin regimens for type 1 diabetes needs to be tailored to the patient's lifestyle, right? So again, given the young age of these patients, it's important to consider like what they're capable of. And honestly, you'll be super surprised by how well versed very young patients may be on their own insulin regimens. I've seen like, 9, 10-year-olds that can carb count and can figure out their insulin dosing better than their own parents can. They can operate their pumps better than their parents can. So it's pretty cool seeing how much of a sponge they are and how good they can get at managing their own disease. But basically, what we would be doing in most cases is a basal bolus regimen where they're doing self-monitor blood glucose readings, right? Basically, mean they get a basal amount of insulin, usually once or twice a day for long-acting insulin, and then they'll get bolus doses of insulin around meal times and perhaps snacks, and then sometimes they'll get like a correction at nighttime. And they'll be using this based off of their blood glucose readings that they're going to do periodically throughout the day. That typically means multiple daily injections. However, you may be able to get away with using just a continuous sub-Q injection, which I'll talk more about here in just a little bit. But as I mentioned, there's a double-edged sword here between more injections and fewer. More often, you get tighter glycemic control, but you're also getting more complexity and more risk for hypoglycemia. If you're injecting less often, only 2 or 3 times a day, then you get less chance of hypoglycemia, but looser glycemic control. That's kind of the trade-off you're going to be seeing with those. You also need to consider matching carbohydrate intake with insulin and physical activity too. So if you have someone who's like a student athlete, they may not require as much insulin if they're going to be physically active because they need that glucose. They need that to be able to operate their muscles and stuff. And so giving them insulin may actually cause them to become hypoglycemic. So you can find that it can be very dynamic in terms of what their needs are for insulin doses. And again, our goal is to let them live as normal a life as possible. So having to, tuck away to go inject yourself with insulin may not be great. But if you have a little sub-Q pump that's just running there on your belt or on your waistline, running 24/7, that's pretty good. It's pretty inconspicuous, I think, as opposed to having that big old backpack, I guess. Ideally, we'd like to have insulin administration be very similar to what the pancreas would do, right? So ideally, if you had some little implant that would be able to detect glucose levels and release insulin in response to that, that would be fantastic, right? We may see that in the future, as time goes on. I'm sure there's some prototype models that are already out there in animals or something. But currently, though, we're not really quite there yet. Although having ways to do like continuous glucose monitoring certainly has come a long way. Some people will have like subcutaneous monitors that will be placed that kind of measures their glucose kind of throughout the day, which is really neat. And that can give them kind of a better sign of like when to use insulin and things like that. But typically, you're going to find that using once or twice daily injections just isn't going to be sufficient for these patients. It's just not going to get them as tight a control as what you need based on mealtime, based on exercise schedules, all those sorts of things. And again, ideally, we'd like to be able to have a device that could do this exact thing automatically. However, we may not be able to get quite there, but we can sort of mimic this using various sorts of injection techniques, or like I mentioned, the sub-Q pump can be really useful there. I think I have a slide on that in just a second. But generally speaking, the insulin doses should change depending on their carb intake and also their exercise. So again, if they're having a more carb-heavy meal, they may require more insulin, right? That's where we talk about the carb counting, and they'll figure out what their insulin sensitivity factor is. They'll figure out how much 1 unit of insulin will change their glucose, and that may be different from patient to patient, right? So they'll be using their short-acting insulins for that. They'll have long-acting insulins usually in the morning time or the evening, perhaps twice daily, depends on the formulation they're using there. And then they'll have the regular or ultra-rapid acting around those meal times. Now, a couple things you'll hear. Sometimes you'll hear what they call sliding scale insulin regimens. You may see this in the hospital done more frequently, where they basically, the dose will slide based off of preprandial glucose readings. They check a glucose before their meal, and then they go ahead and take an insulin dose to help correct that. And again, they usually will have an insulin sensitivity factor that will show them how much 1 unit of insulin will lower their glucose, and then they basically can just take their glucose, whatever they need to correct, divide it by that factor, and then they know how many units to take, basically, right? And then there's carb counting, where basically you're adjusting the insulin dose based off of their anticipated carbohydrate intake, right? So if you can use things like, it's actually probably a lot better nowadays with stuff like, MyFitnessPal and things like that, where you can actually get pretty good estimates of carbohydrate amounts. But some people just know the stuff by heart, especially if they're on a consistent diet, and they'll know just how many insulin units to take based off of the carbs that they're consuming. So more carbs, more insulin, basically. So how this would look, so imagine if you had someone with normal plasma glucose concentrations, right? So the basal glucose, and you see these peaks that are stimulated by meals, and then you have what normal plasma insulin concentrations would look like, okay? So ideally, we'd like to mimic this as best we can, and you can see you get actually pretty close to that if you're using like a sub-Q pump, right? So you can notice here that basically the patient would have a basal rate that's set, that's infusing consistently, and then based off of their glucose readings and based off of the carbs that they're about to consume in their meals, they can program in a bolus. They can basically just say, okay, I'm going to inject 3 units for this meal. Next meal, they may do 2 units, whatever the case may be. And that will basically cover them. And their glucose should be pretty tightly controlled, assuming that their diet's consistent and they're accounting for their insulin sensitivity correctly. And again, these patients get really good at doing this, especially the really compliant ones. So if you're using like less, if you're not going to have a sub-Q injection, if you want to do something just with intermittent injections, which is probably more reasonable for most patients with their first diagnosis, you can see a couple of different options here. So here would be an example where you could use something like a regular insulin at twice a day, and then they're giving NPH insulin twice a day as well. So you could actually do this in just 2 shots. So you could see where basically they'd have the regular insulin peak up in the morning, and then as that starts to decline, then their NPH insulin will start to take over for them. They'll have a later peak and will take over for the lunchtime bolus of glucose. And then they'll take a second dose at supper time, and they'll have the regular insulin cover that, and then the NPH will kind of cover over the nighttime period. Okay, that might be okay, but you probably want as tight a control as what you're really looking for. So more frequently, what you'll find is that patients will be on usually a really long-acting form, so probably not ultra lente, but more often like Degludec or Levemir or Glargine, something like that, or Lantus. They'll be on that one time in the morning, and then they'll have usually a rapid-acting insulin, usually like a Lispro or something, or a Humalog, that will be given basically at breakfast, lunch, and dinner. Sometimes they'll have a nighttime correction based on what their glucose is there. And then there you go. They might be only doing, say, 4 to 5 injections in a day. So tighter control, but more cumbersome than if they're just doing a 2 injection strategy. Okay. So you can kind of compare and contrast and see that there's trade-offs with each one of these. Obviously, the most natural way is to do with the pump, but that may not be reasonable for all patients, especially if they're not particularly compliant. There's some other issues you can run into that with that as well, right? So I'm not going to ask you specific dosing. You may get that in CMS. I'm not really sure. But just to give you some ideas of how we dose different patients with insulin, you can see here that for a typical type 1 diabetic patient, they're getting 0.5 to 0.6 units per kilo per day, as opposed to a type 2 diabetic patient getting 0.7 to 2.5. Your question is like, well, why is that type 2 patient who can't produce their own insulin require so much more than a type 1 patient who cannot produce their own insulin? Well, goes to insulin resistance, right? Because the type 2 patient has probably had pretty consistently high glucose levels for a long time, years and years and decades, and had high commiserate high insulin levels. They've developed resistance to that. So they require really big doses. So you will always find type 2 patients, can't think of any good exceptions, where they're going to have a higher insulin requirement for the most part than a type 1 patient. Because type 1 patients typically don't have a huge amount of insulin resistance because they just don't make a lot or any. You find typically once you get their total daily dose, you'll spread that out as 50% being the basal, so the long-acting form, so Glargine or Lantus or whatever, it'll take throughout the day. That will be active throughout the day. And then the other 50% will be the regular rapid-acting that will be around mealtime, right? So then you can break that down. So let's say, for instance, you had a 40-kilo female who got diagnosed with type 1 diabetes, basically saying, okay, well, let's go ahead and start out on, 0.5 units per kilo per day. She's 40 kilos, so they're going to get 20 units per day. How do we divide that up? Well, let's go ahead and do something like 50% is the basal, so maybe we'll do insulin detamir twice daily. So we do 5 units in the morning and at night. Probably more often than not, you probably just see that one time daily, but you do 10 units in the morning. You could do that. And then 50% is the bolus, where most people probably have more carbs in their breakfast than in their lunch and dinner. May not always be the case, but generally speaking. So they do 20% at breakfast, say 4 units of insulin Lispro, which is that quick acting with breakfast, 15% at lunch, 15% at dinner. And again, you're monitoring, you're seeing how well their glucoses are doing, checking their A1C, over the course of 3 months or so, and then adjusting as needed. Everyone's a little bit different. Everyone's diets are different. People have different backgrounds, and everything can be affecting this. Different exercise regimens. Some are student athletes, some are not. Just a million factors that go into it. But that's generally how you're going to start out most patients for the most part. For most type 2 patients, you probably wouldn't be doing a lot of mealtime insulin. You'd probably just be starting out on a basal insulin amount, just to help cover them throughout the day. Because again, they have a more of a basal problem with that insulin resistance. So that's why you're going to be hitting them mostly just with a long acting for the most part. So, as I mentioned, insulin pumps really handy. They can help to provide that sort of basal and bolus dosing throughout the day. They'll just be set to a normal basal amount of insulin release that they'll be pumping out consistently 24/7. And then you can program in the boluses as need be based off of mealtime, your preprandial glucose readings or mealtime carbohydrate intake, all of that. Yeah, so for the basal 50%, so it would be 10 units. But yeah, so because it was divided BID, you do 5 in the morning and 5 at night, right? So keep in mind, depending on how often you're giving it, that would be then divvied up based on this scenario. If you're just doing it one time daily, then it would be 10 units of the long acting in the morning. Yep. So with this though, you need patients that are really like well invested and really sure what they're doing, because it's very easy to overdo it and become hypoglycemic if they skip a meal. But they go ahead and give themselves a bolus anyway, or whatever the case may be. You have to be really careful because that pump is going to pump no matter what. It cannot check your glucose for you. We're not quite there in terms of technology yet. So the patient does need extensive training, and pump malfunctions do happen, right? We expect all technology to be perfect, but it can fail just like anything else, right? And so you can find cases where pumps may break to where they're not releasing really any insulin, so the patient gets hyperglycemic and has to come in for that. Sometimes it is pumps too much, or something happens with the programming, gives you too much, and the patient's found hypoglycemic, right? So again, think about the type of patient who this is going to be good for. Someone who is really with it, someone who understands their regimens and how to calculate this stuff, someone who is going to be responsible with it. If you have someone who is like maybe not aware of how to do the math to do this, or if you're like a really, really young patient who could not figure this out, right? They might not be a good candidate for insulin pump. Someone who is known to be quite non-compliant, that's not going to be a good candidate for this, right? So you'd be really careful with this because, again, the potential for error goes up if you're not really going to be all that committed to it. And so that's why I stress that point, because you want to make sure that the right patient is going to be using these pumps here, because it's really great for them if they can do that. It's very good for their quality of life and lifestyle, but they got to be with it. They got to be really kind of invested there. Anyway, so what do we do for hypoglycemia? Let's say we give too much insulin, or the patient, exercise, but they still give themselves a dose of insulin. You can run into some issues with this. Obviously, educate them on the signs and symptoms of hypoglycemia. The tremors, the sweating, the anxiousness, all of that goes along with that. However, be aware that, patients may develop autonomic neuropathies. They may not experience those signs and symptoms of hypoglycemia. Remember, we talked about beta blockers. Beta blockers block the effects of hypoglycemia, so they may not even realize that they're hypoglycemic until it's too late, right? Till they have some altered mental status. But basically, we're going to be trying to correct for anything less than 65 or 70 milligrams per deciliter. It's considered to be hypoglycemic. You tend to find, and I don't know if you guys have ever been hangry before, but you probably overdo it and end up getting too much food in. Then you have hyperglycemia you're having to deal with too. Obviously, much less dangerous of being hyperglycemic, maybe not in the long term, but at least in the short term. But patients tend to overdo it. So here's the general rule of thumb for being able to correct hypoglycemia, right? Basically called the rule of 15. They go ahead and they consume 15 grams of simple carbs, right? So easy to digest carbohydrates. So consider something like 8 ounces of orange juice or milk, or oftentimes they will have glucose tablets that they can purchase or be prescribed they can take. And then they go ahead and check their glucose in another 15 minutes. And if it's still less than 70, then you go ahead and give them another dose and wait another 15 minutes, and you kind of repeat that until there should be above 70. Hopefully they'll feel better once they start to get that glucose into their system, right? Other ways we can do this, especially if a patient is unconscious, oftentimes they're going to be given a prescription for a glucagon injection. It's called glucogen. As a brand name here, you can see that this is kind of designed for quick administration. So again, they even give you directions on how to do it, so that way they can administer it. Because glucagon itself is a protein, and you want to make sure that it actually comes as a freeze-dried powder. So you do have to inject the diluent in here, swirl it around to reconstitute it, then draw it up and then inject into the patient. This is due to a stability issue. If this was as a liquid, it would not be good for very long, and you never know when you might need it. So that's why it comes as a dry powder like that. But anyway, you can give glucagon to a patient, and that will basically stimulate glycogenolysis and gluconeogenesis in the liver to raise their blood sugar. So again, if someone's unconscious because they're hypoglycemic, you can't really like shove glucose tablets in their mouth. It's not going to be all that safe for them. So instead we can use glucagon as an IM injection, and that way they can go ahead and get it into the patient, cause the glucose to be released, and then hopefully fix the hypoglycemia. Interestingly enough, we will also use this to help with actually one of the big side effects of glucagon is a lot of nausea, vomiting, and this has to do with the fact that it causes relaxation of certain areas of the GI tract smooth muscle, and that also includes the lower esophageal sphincter. So sometimes we actually do, for patients who have ingested a foreign body, is we will oftentimes give them glucagon to see if they can pass it past the esophagus into the stomach, and things become much less dangerous once they're in the stomach as opposed to in the esophagus. So if you recall, I don't know if I told you guys about my daughter, my little one Phoebe. She actually ate a bobby pin one time. Had that bobby pin been stuck in her esophagus, and maybe the GI people didn't want to come in to come remove it, maybe it was overnight or something, they probably would have recommended giving glucagon to have that pass down to the stomach, where it's much less of a concern there from a just a sort of obstruction sort of standpoint. We'll do this for coins and batteries and stuff like that, depending on the situation. Oftentimes it doesn't work, but that's an indication you may see it being used for there. Don't worry, she ended up being fine. She pooped it out, no problem. But I can't remember if that was your guys' class or the last class I got to hear about that. But yeah, Phoebe's a wild child for sure. Anyway, so this is probably not great for patients with like long-standing hypoglycemia, mainly because if you don't have glycogen stores in the liver, then you can't produce any more glucose anyway, so it really won't be all that effective for them. And if you can't give them some Zofran or something, because the nausea vomiting is pretty wretched with this, I use glucagon quite frequently for beta blocker overdoses. This is kind of an interesting way we can use it to increase contractility of the heart. Using that, so actually I had to do this just the other night when I was on call, recommending it for a patient who had a beta blocker overdose. Phoebe is so silly, certainly is. Anyway, so glucagon is a good way to go, especially if maybe they're like on an outpatient at a hospital sort of setting there. We'll still use it occasionally in the hospital, but more often than not, we're going to just give them dextrose, right? I'm not sure if they're coming on P's Day. I don't know if I can get them out of school for that, but we will see. Anyway, so from the other thing you can do is just give them more dextrose, right? Give them what they are requiring. And so dextrose, pretty close to glucose, right? So basically this comes in a fair number of concentrations, the main ones being D10, D25, D50. I think most of you are probably familiar with D5 that you see in a lot of like IV fluids and things like that. That refers to the concentration, right? So when I say D5%, that means that there's 5 grams of glucose per 100 mLs, or D50 means there's 50 grams per 100 mLs. And so just be cautious with the concentration that you're using. Typically, you'll see here that the dose is 0.5 to 1 grams per kilo. Usually we'll max it out at a single of 25 or 50 grams, depending on how hypoglycemic they are. But that amount of fluid that they require changes based on the concentration that you're talking about. So obviously D50 being most concentrated requires a lot less fluid to be administered. The challenge you run into is that the higher concentrations can cause a lot of irritation to the veins. So if I'm using something like D50, especially like in a small child, I'm trying to put it through those really tiny friable veins, I'm going to cause a lot of pain, irritation to the tissue. Typically, we try to use D10 for the really little ones, like the neonates, D25 more so for like children, and D50 you can use it for adults, especially if they're like coding, unconscious, like D50 may be used in those cases there. But if you got time, use lower concentrations. It's usually no problem as long as the patient can handle that fluid there. So anyway, so those are kind of the ways we help to manage a type 1 patient most typically. Again, replacing the insulin that they're missing. Make sure you kind of understand the different types of insulin and how we would use them differently. So if I say which one of these would be good for basal control of insulin, right? That'd be a pretty simple question I could ask. And I put insulin glucosine. You'd say, well, that's not good for basal control because it's a really rapid acting. It wouldn't help me throughout the day, right? Versus insulin degludec would be a good option for that because it does last throughout the day. Now, I could also ask you maybe a more complicated question to say, like, okay, a patient is diagnosed with type 1 diabetes. Which one of these regimens would make the most sense? And maybe I'd say insulin glucosine 1 time daily with insulin degludec 3 times daily with meals. And you'd say that's incorrect because I'm using a long acting for the bolus doses and a fast acting for the basal. That's not right. You have to switch that, right? Those might be something I could consider asking, right, on a sort of a more of an application basis, more so than you know, just strictly which one of these is long acting. That's fairly simple to know, but I care more about the actual application of this information. So that makes a sense. Um, anyway, so again, you may find as well that you know, treatment goals, especially for type 2 diabetics, may change over time. You know, glucose ranges may change. Typically, lower is better in a lot of cases. You know, to within a degree there. But certainly, when monitoring patients, especially with type 2 diabetes, you're looking at A1C, you're looking at pre and postprandial glucoses, all of that. Of course, I want to talk about the medical therapy for type 2 diabetes because that's kind of bread and butter kind of stuff in terms of meds. Certainly, lifestyle changes are always going to be ideal. If they can get their diabetes under control just with lifestyle, Bob's your uncle. That's fantastic. I hope everyone could do that. Unfortunately, in a lot of cases, that will not be sufficient. So we're going to look at using monotherapy. We'll look at, and again, this is oral medications typically. So using our combo therapy after that, if that's still not working. And then looking at combination therapy. Typically, this is when we start to consider using oral drugs along with insulin, but we'll look at some other injectable options as well. So, looking at this is kind of interesting. If you're looking at like plasma glucose versus plasma insulin, oh, some question here. Someone said, what were intermediate acting meds used for? So that would be a case where instead of doing like once daily insulin glargine, like a really long acting one, you may do like twice daily NPH insulin or something. That way, they would provide you coverage throughout the day. It just would have a little bit more of a peak effect, but that would be like a twice daily sort of regimen there. That's what I would see the intermediate use. And you can look back on that slide where it showed the different regimens. So you saw that twice daily NPH being used in that case there. How does glucagon help with a beta blocker overdose? Yeah, so basically, without getting too much into the weeds and getting off topic, so if you have a beta blocker sitting on the beta 2 receptors on the heart, or sorry, beta 1 receptors on the heart. Look at me screwing that up. My gosh. So if you have beta blocker sitting on the beta 1 receptors on the heart, you're decreasing contractility because normally you would find that things like epinephrine, norepinephrine stimulate the beta 1 receptors, and that stimulates cyclic AMP to be produced, and that stimulates contractility, all that good stuff. So if I'm blocking the beta receptors, we would see like, okay, well, there's got to be some way I can increase contractility, but if I can't use the beta receptors, what can I do? You can actually use glucagon as sort of a backdoor method to increase cyclic AMP production in the heart because it gets absorbed in the heart, regardless irregardless, it's not even a word, regardless of, you can tell I'm getting a little tired in terms of speaking today. I'm using all kinds of misused language here, but glucagon is able to get into the heart cells and is able to increase contractility by sort of directly stimulating cyclic AMP production. So that's how that works basically. It does work fairly well. I've had some good instances of that use actually. Priya's asking, every insulin we've talked about so far has been sub-Q, not PO. Yes. So every insulin is a protein, and so if we try to use those proteins orally, it will just get chewed up by the stomach and stomach acid and whatnot, because just like any other protein would be, right? So we can't use those PO. There one was inhaled. I didn't get too much into that, but that could be a special use case for patients who maybe are extremely needle phobic and don't want to use multiple injections a day. Again, I've never seen it used in person, but yeah, so all of those have been injectable so far, which again is why it's is disruptive to their lifestyle. They have to inject themselves. It's not fun. They get skin infections, so good sterile technique is really important to educate them on. So it's a lot. That's why diabetes educators are like super, super helpful because even though PAs have a lot more time with patients, you may not have enough time to really go through all the ins and outs of diabetes management. And so that's where things like dietitians are super helpful. That's where diabetes managers are really helpful, and educators. So you utilize your resources. That's why they're there, right? And they love doing this. So, oh, that's awesome. Very good to hear. Anyway, so looking at someone had a question. So if you ask us on the test, what would be the best treatment for type 2 diabetes? The answer would be lifestyle changes. I mean, I guess so. I don't know if I would like put that as a question on the test. I may say, a patient has failed lifestyle modifications, what would be the next best medication to use? And so maybe picking the initial selection might be an option. But I don't know that I'd ever ask a question where I would give you like lifestyle modifications as a choice along with a bunch of drugs. I feel like that would be like kind of a trick question. I think most people will be pretty unsure about that kind of question. So I wouldn't do that to you. I'll make mine all drug based. Anyway, yeah, maybe she can teach us some stuff too, Jackson. You never know. Um, So looking at this, if you were to compare like glucose levels versus insulin levels for someone who had normal glucose tolerance, impaired glucose tolerance, and then type 2 diabetes, you see a pretty stark contrast here. So again, the glucose levels obviously for the type 2 diabetic patient go up the most, but as you can see here, they also don't produce as much insulin, right? So in even the person who has impaired glucose tolerance, they produce much more insulin, but it's like very sustained, right? And so again, this is the issue we're running into. Either they're having a lot of resistance requiring much more production of insulin, or they're just starting to run out. So we need to find some ways to try to sensitize the body to the insulin to try to be able to utilize the insulin, or utilize the tissues to be more sensitive to the insulin they're producing, or we may need to replace that insulin altogether, as the case may be. That's well, sometimes anyone is teachable. I would say. So you're here in PA school, you're learning a bunch of stuff. I think you're fine. You guys are too hard on yourselves. Give yourselves more credit, I think. We also find as well, this is another really interesting point here, is that if you're looking at someone with normal glucose tolerance versus type 2 diabetes, looking at their insulin release, again, you see with normal glucose tolerance, you have a huge spike and then it drops right back down, right? As opposed to someone like impaired glucose tolerance, they have a spike, but it's much more prolonged. The insulin of a type 2 diabetic patient may never get to the same peaks because their beta cells are starting to be worn out and they're just not producing as much. The other really big point here, which we're going to focus on with some of our newer classes of drugs, is the fact that glucagon remains elevated for type 2 diabetic patients. You see here, elevated glucagon levels regardless of this big spike in glucose, as opposed to someone with normal glucose tolerance. Their glucagon levels should drop down to almost nothing in response to high levels of glucose because your body doesn't need gluconeogenesis, right? It doesn't need to release that. So that's going to be another big problem. So we may be focusing on this from the insulin side of things, or we may try to focus on it from the glucagon side of things too. So some of the newer classes we'll look at. So here are the general classes of drugs we're going to get into and how they work for diabetes. So first off, we'll have the sulfonylureas and meglitinides. These are good to stimulate the pancreas to make more insulin, right? So instead of giving someone a shot to give them exogenous insulin, this will help them to produce their own, okay? We will have drugs that are called insulin sensitizers that help with controlling hepatic glucose production, help out with peripheral uptake of glucose, things like that. That's where we get into our biguanides and thiazolidinediones. Hard to say, so we'll talk about some other ways we can talk about those drugs here in a minute. We will look at drugs that directly block the absorption of starches. So those are called our alpha glucosidase inhibitors. We will also look at things that can suppress glucagon, suppress gastric emptying of food intake, as our incretins or glucagon-like peptides, that newer class I talked about. And then actually the newest class are going to be the SGLT2 inhibitors that block reuptake of glucose from the renal tubules. It's a really interesting class that we'll look at, very novel. So, and you can look here to see sort of the different comparisons between drugs in terms of how well they're going to work to do things like reduce A1C and fasting plasma glucose. So you can kind of get a various comparison. Generally, they're all pretty effective. You'll see some are a little less effective than others, but we'll see how we may be able to utilize them. And honestly, you're going to see a lot of combo therapies here. You're going to see a lot of things that have like that'll say Janumet or Glipimet or something like that. Usually, you'll see a lot of combo drugs, and we'll talk about met and what that kind of means as a suffix here in just a little bit. But you'll see a lot of combos because it helps out with compliance. Because not only do these patients have type 2 diabetes, but what else do you think they probably have? They have hypertension, they may have CHF, they may have, all kinds of other disease states, which may necessitate them being on a ton of other meds. So again, compliance becomes very challenging. So looking at sulfonylureas, we can see here a couple of drugs in our first generation category. So we have acetohexamide, chlorpropamide, talazimide, and then tolbutamide. To be honest, out of this category here, I really just care, chlorpropamide is the only one I ever see being used anymore. And then with the second generation drugs, all of these are going to be used pretty extensively. So glimepiride, glipizide, and glyburide. Are there not any that block fructose? I don't know of any drugs that specifically block fructose. Maybe like the alpha glucosidase inhibitors to a small degree. I'll talk about that in just a second there. But anyway, yeah, you should know all the second generation drugs and chlorpropamide. Basically, the second gen drugs are more potent, but they have fewer side effects. And again, we're going to find the side effects are make a lot of sense based off how the sulfonylureas work here. Notice a lot of these come as extended release preparations as well. So for instance, Glucotrol XL, that one's kind of interesting because you have to educate the patient that they may see the pills come out in their poop. The reason why that is because the tablet itself has basically it doesn't dissolve like a normal pill does, but it has a tiny hole that is drilled into it. So that way, osmotic pressure forces the drug out of that tiny hole in the pill over the course of its travel through the GI tract, and then they poop it right out at the end because it doesn't break apart, but all the drug's gone. And so some of the patients will complain. They'll say, "Well, it's not working because I just found it in my stool. What's up with that?" You have to tell them, "No, no, it did what it's supposed to do. It's just how the drug is designed." Kind of unique sort of dosage form there. But how does the sulfonylureas work here? Basically, instead of requiring glucose to come in to be converted to ATP to close those potassium channels, this will do this directly. So these will actually go in and block those potassium channels directly, causes depolarization, opens up calcium channels, and then you have more insulin being released. Okay, so again, kind of bypassing what is normally needed, even though this process is probably still happening. But again, this is just one way to circumvent that and cause much more insulin to be released than would be normally. So you should be expecting to see less hepatic glucose production because you have more insulin affecting the liver. You should see hopefully more sensitivity and more number of receptors, of insulin receptors and glucose receptors. And then because you have more insulin release and to some degree somatostatin, that will suppress glucagon levels as well. Okay, so ideally that would be the way that this is going to be working here. You'll see most of these are metabolized in the liver. Some have some active metabolites, but aren't really clinically that concerning there, and they'll get excreted into the urine. Generally speaking, you may find a few protein binding interactions. They don't come up all that too often there. I really would be cautious in renal failure, mainly because of the fact that the insulin that they're releasing is going to have a longer half-life, right? Just like we talked about before, how hypoglycemia can be caused by renal failure through that mechanism there. This one's not great for pregnant patients, mainly because it can cause depletion of insulin from the fetal pancreas. So not great. So I would not recommend that by any means. Some of these you want to be really careful with because obviously the biggest side effect is going to be hypoglycemia, right? Because you're releasing all this extra insulin. But as an example, chlorpropamide might be really dangerous in especially elderly patients because of its really long-acting nature. And it has sort of the highest number of side effects because of how long it's lasting, can cause pretty significant hypoglycemia. This is also interesting because it can cause a disulfiram reaction, just like metronidazole does. So you want to have them not take alcohol along with their chlorpropamide. And you're going to find that chlorpropamide glyburide are probably the most likely to produce hypoglycemia. So they definitely need to know how to monitor for that, make sure they're checking their sugars, making sure they know how to do that rule of 15, all of that to make sure they don't get hypoglycemic. And honestly, I've seen some pretty nasty cases, especially with kids getting into these sulfonylureas, where they can be hypoglycemic for like 2 or 3 days, or having to give them like consistent glucose infusions in order to help manage that. It can be pretty nasty from a overdose standpoint. But again, you're going to see that if these drugs are used in conjunction with insulin, you do need to reduce that dose of insulin that they're going to be administering. Because again, they should be producing more of their own at that point there. And again, they help for rapid glucose control, but the risk for hypoglycemia does go up. Okay, so it's kind of the double-edged sword with something like a sulfonylurea here, right? With glyburide, as I mentioned, probably very commonly associated with hypoglycemia here. And then glipizide itself, usually you will find that it works a little bit better if you do it 30 minutes before meals. Has a little bit better absorption. This one has a shorter half-life, which is why it has that XL formulation, so also a little less hypoglycemia. Just in general, though, know that the sulfonylureas, hypoglycemia is the main side effect you're worried about, right? Again, how to manage that if that does occur. You're also going to see some weight gain associated with that, just like you would if you were to give them exogenous insulin. Some other things you may see include some blood dyscrasias. This is very uncommon to occur there. And you will see resistance over time because, again, these patients typically already have overworked beta cells to begin with, and you're now increasing that pressure on them to work more, and so they may wear out even faster. So again, this could be something that's good for a while. They may find they're going to be less effective as time goes on. It could be related to just further beta cell dysfunction. For this patients here, in terms of contraindications, this would not be good for DKA because in type 1 diabetic patients in general, just because, again, they don't have any insulin to produce. So this is not really going to do anything for them. And again, in terms of interactions, this is going to be more so of an issue in terms of other drugs causing hyperglycemia. So if you mix and match, say this, like glipizide plus insulin, yeah, your risk for hypoglycemia is gonna occur more likely. But also, if you have drugs that are going to be causing hyperglycemia, like corticosteroids, this will decrease the effectiveness. So, from a pharmacodynamic sense, I think that makes pretty good sense there. And again, chlorpropamide, just watch out for the disulfiram reactions. So, sort of similar, sort of cousins to the sulfonylureas, we have the meglitinides. These are not used too often, but this is called repaglinide and nateglinide, and these are going to do basically the same thing as the sulfonylureas. The key difference, though, is they only work relative to the glucose level. So if you have high glucose levels, like due to a meal, then these will work better. If you don't have any kind of mealtime glucose coming in, these drugs really don't do a whole lot. So their risk for hypoglycemia is a lot less because than the sulfonylureas, because sulfonylureas work regardless of whether glucose is high or low. These will only work if glucose levels are high. So maybe a little bit safer than the sulfonylureas. Overall, probably a little less effective than those. Oh boy, I have a bunch of questions here. Someone says, as far as mechanism of action goes, is it important that we know the sulfonylureas stimulate pancreas to make more insulin, or do we need to specifically know this is done by blocking ATP-dependent channels, causing depolarization? If you know that it directly causes the pancreas to release more insulin and can identify the difference between like the meglitinides versus sulfonylureas, I think that's good. To my mind, I think that it helps you in understanding the mechanisms. If you kind of know that, yeah, I could say, okay, they increase pancreatic insulin release. That's a mechanism. Yeah, that's true. But I think in terms of like kind of understanding things, it's nice to know the background a little bit. That I think that just solidifies in your mind a little bit better, right? The whys of things, how they happen there, right? So at least that's my mindset. If you just want to know that little base amount, then that's probably fine for most cases. Some have, so if a patient had high levels of albumin and sulfonylureas are highly protein bound, how would that affect the medication? Probably not a huge effect. You don't really see patients like hyperalbuminemia. More often than not, you run into cases of hypoalbuminemia, where that would cause a higher free fraction of the drug to be available, which can cause some hypoglycemia if that was the case. But usually don't run into a lot of issues of patients having too much albumin unless like you gave it to them potentially. So clinically, I don't know that would come up too often. Does glyburide have worse hypoglycemia effects than chlorpropamide? They're probably pretty equal to one another. So I've seen chlorpropamide used every once in a while, but mostly it's glyburide and glipizide and all that I see used a little bit more frequently. But yeah, they're probably about equal there. All right. So anyway, so again, the teglinide, the meglitinides are different than the sulfonylureas just in that they only they require high glucose levels for them to work. You can see pretty similar actions here in terms of like hepatic metabolism, high protein binding, all of that. Just note that these need to be taken before meals, usually between 10 minutes and 30 minutes in order for them to really be effective, right? That coincides when you'd had the bolus of glucose being absorbed from the GI tract anyway. You may see this used with metformin, but you don't see it used. I mean, honestly, these are used less frequent than sulfonylurea, so you probably won't see a lot of other combo products with these. But again, metformin is usually the backbone to a lot of different, diabetic regimens there. And you should tell patients if they miss a meal, go ahead and skip the dose. No point in doing that because it really won't do any good for them. Yeah, so someone said, can you repeat the MOA for meglitinides? So the difference between sulfonylureas and meglitinides is sulfonylureas, they will increase pancreatic insulin production no matter what your glucose levels are. If they're high, they're low, they're going to increase the amount of insulin you have there. So if I have someone who's like hypoglycemic and I give them glipizide, they're going to get even more hypoglycemic. If I gave someone a meglitinide who is hypoglycemic, it wouldn't do anything because it requires higher levels of glucose for it to really work, which is why you say if you skip a meal, you don't have higher glucose levels because of the meal, then you go ahead and skip the dose because it really won't do anything. That's really the key difference there. The meglitinides require higher glucose levels in order to be effective. If that's one way to simplify it. All right, let's see here. Again, similar side effects, probably lesser than you would see with the sulfonylureas. So that's going to be kind of the big difference there. Just a little bit better tolerated, but a little less effective overall, I would say. What I do want to talk about is the biguanides. There's really only one in this category we're going to talk about here, but it's metformin. This is like the grandpappy of type 2 diabetes drugs here. This is what you're going to see most patients being started on for for diagnosis of type 2 diabetes that requires medical management. Metformin is it for the most part. There's a few other forms that are out there. Some have been removed from the market due to issues of lactic acidosis. This will be important for metformin as well here, just a little bit. And you will frequently see it used in combination with a lot of other drugs. So if you ever see a diabetes drug and has met in the name, that means it's a combo of something else plus metformin. So for instance, like Metaglip, Avandamet, those are just examples we'll get into in a little more detail there. But a lot of combo products because it helps with compliance And also, it's a new patent, so they can make some extra money off of that, I suppose. But again, compliance is the main goal there. So what does metformin do? You think about this as an insulin sensitizer. Basically, it makes whatever insulin you are producing work better. And it does that by doing things like decreasing hepatic glucose production. It will do things like increasing peripheral glucose uptake and utilization. So that's that sensitivity there. It's also going to decrease glucose absorption from the GI tract. So overall, it doesn't do anything to make more insulin, but it helps the insulin that you have available work that much better. And because of that, it also has very limited hypoglycemia, which makes it very attractive to use as a first-line drug for someone with type 2 diabetes, because they don't really have to worry about hypoglycemia. It's really a very low risk for those type of patients there. Now, there are some going to be some downsides of metformin. It's not a perfect drug by any stretch of the imagination. And it's actually not even metabolized in the liver. What's actually kind of interesting is that it is purely excreted through the kidneys. And you cannot use it in kidney failure, because some of the problems are going to happen if you cannot get rid of that metformin. We're going to see some really nasty side effects from that, as we'll see in just a moment there. The other nice thing too is this is good for patients with like insulin resistance and hyperlipidemia. It also can, if anything, actually cause some weight loss. So that could be good for like obese patients, which many type 2 diabetic patients have a tendency to be overweight or obese. And it also doesn't cause any weight gain, because you're not releasing any more insulin. So that's kind of a key differentiator there. And again, another reason why metformin is good is like a first stop for a lot of type 2 diabetic patients, right? Because it can help out with their weight. Shouldn't cause them to gain any weight like a sulfonylurea definitely would. Okay. So from adverse effects, a lot of these things to think about. One is going to be the GI effects. This is really rough on the stomach, can cause diarrhea, constipation, unpleasant taste. Just a lot of issues which may lead patients to not want to use it. In those cases there, we actually have an XL formulation, which may be able to help mitigate that by kind of slowly releasing the drug throughout the day, as opposed to kind of getting all of it at one time, but that's generally more expensive. I'd probably try immediate release first if possible. Other big thing to worry about too is this lactic acidosis. This is going to happen in patients with renal impairment who are not being watched and being stopped from taking metformin. So if you say start a patient on metformin when they're in their 60s, and then they're on it into their 70s and they're 75 or 80 now, and no one's ever gone back and checked their renal function, that's where they can get into trouble here. So renal impairment, especially after surgery, especially if you have like sort of acute, maybe decreases in renal blood flow. We also see this as well when we talk about things like patients going to get imaging, because you can see that contrast dye can hit the kidneys, which can lead to lactic acidosis as a result of metformin. Okay, basically it inhibits the ability for the liver to process lactic acid and get rid of it, and so it builds up, and so you get a really nasty metformin-induced lactic acidosis, which has been fatal. It can certainly be fatal. I've seen a couple of cases of that for sure. This is one thing to watch out for. Another thing is rare is megaloblastic anemia. This has to do with B12 absorption. Generally not all that too big of a problem, but if you're checking their CBC, this would be one thing you could look for too. So as I mentioned, renal disease is going to be the major contraindication. So if their GFR is less than 30, you cannot use it. We used to recommend it based off of like their actual serum creatinine. We just got rid of that and just said, okay, if their GFR is less than 30, don't use metformin. Certainly if they already have a metabolic acidosis or hypoxia, this is not going to be the drug to use at that time until you get that resolved. If they have hepatic disease, which is impairing their ability to process lactic acid, also not going to be used there. And then you will see some interactions in terms of renal excretion. So again, you can look that stuff up. I'm not going to go through the entire list there. And so this is, again, why we need to stop it before surgery. Typically, withhold it for about 48 hours after surgery due to that, not only can you have kind of acute hits to renal blood flow during surgery, but sometimes just that process of inflammation due to surgery can develop some lactic acid. So that way we can just hold the metformin. Again, if someone's hyperglycemic, you can always correct that with insulin. You can always do that, no problem. But metformin definitely needs to be held for that time frame there. And certainly before getting contrast dye, we like to withhold it if we can, because otherwise, you can see that contrast-induced nephropathy, which can lead to metformin not being processed unless you get that lactic acidosis. Okay, metformin, and again, I'll talk more broadly about how we're using these drugs and how you select which one versus another towards the end of the section here. I'm just trying to get through all the medication classes first. Next up, we have the thiazolidinediones, or you just call them the glitazones. I think more people just tend to call them that. This includes a couple of drugs here, pioglitazone and rosiglitazone. Proglitazone was used for a while, but it got removed due to liver toxicity issues. And so the way this one works is they're going to be an agonist versus peroxisome proliferator activated receptor gamma, or PPAR gamma, is the way we sort of abbreviate that. And basically what it does is it helps out with sort of this transcription of insulin responsive genes. And so by activating this PPAR gamma receptor, we're causing more transcription of these insulin responsive genes, and thus we get more insulin sensitivity. Okay, so while this is also an insulin sensitizer similar to metformin, we're going to see this may not be quite as effective. It's going to be more of an add-on sort of medication to those, as we'll see here in just a little bit. So what they're going to help out with is peripheral glucose uptake and utilization, because the insulin is going to be hitting those receptors, is going to be able to be more effective. And we're also going to see less hepatic, actually I have a mistake here, it should be glucose production, apologize there. So we're going to get less hepatic glucose production. The liver does not produce insulin. You're going to get less hepatic glucose production and more glucose uptake by the peripheral cells. Things to watch out for include the fact that it's liver metabolized, so you may want to watch out if they have liver dysfunction. And it does take several weeks for it to really kick in and get full effects. Insulin, pretty much immediately effective within the course of several hours. This stuff does take some time to kick in there. In terms of adverse effects, people you want to avoid this in are typically those with like pre-existing cardiac conditions, especially CHF. So in this case here, this can cause expanded blood volume, can cause edema, and can lead to heart failure exacerbation. So if I was asking you, say there's a question where a patient is on metformin, but their A1C is still elevated, they're not really getting to their goals, what would you want to add on? And I said they have a past medical history of CHF. This would not be the class of drugs you want to use. You probably want to go with something else in this case here. Here you can see a little bit of weight gain. So again, not ideal, but not as much as you would see with like a sulfonylurea or insulin or something like that. And then you will see some kind of variable effects on their lipids, so you wouldn't want to watch for that. And then check their liver function test for sure. Certainly if their ALT goes up 3 times upper limit of normal, probably want to stop the drug at that point. So certainly want to watch for that. So, rosiglitazone is kind of interesting because it has sort of a notorious history here. There was some concern that utilizing rosiglitazone actually caused heart attacks. They were really concerned about that. And basically, it wasn't any individual trial, except for unless you actually combine them all together. And you can see here, there's very few p-values that are significant unless you combine all the drugs, all the trials together there. So while it's still on the market, I probably still wouldn't want to use the glitazone for patients with history of cardiac conditions like previous MI, CHF. I probably would avoid the glitazone just because of the theoretical risk here. And just if you don't want to play with fire, just use something else. We have a lot of other more effective agents available to us. So the glitazone's kind of out of vogue for a little in some cases there, but it's still can have some use in the right patients. Some say if a patient was on metformin for several years and developed CKD over the years and now has a GFR 45, would you discontinue the metformin and change the regimen, even though they haven't reached less than 30, kind of preventative care for the kidneys? I don't know that I would jump to removing it. I would probably, every patient's a little different in terms of how confident you are that they're able to follow up with you. What was the genesis of their CKD? Was it because their diabetes isn't well controlled? Maybe you should be looking at that, right? If you get the diabetes under control, maybe help kind of halt that CKD, or is it maybe due to something else? So I don't know that I would necessarily stop them right then, but if they're pretty consistent with follow-up, if you're confident you can follow that patient there, and they're otherwise getting good effects out of it, then I'd say keep them on it, right? If you weren't really sure that it was really doing its job, if you were not, if you're concerned they may have sort of variable, renal function, maybe that would be a case to go ahead and remove it. So ultimately it comes back to, it depends, right? So someone's asking about, can you explain how metformin can lead to lactic acidosis? It has to do with it blocking the liver from being able to process the lactic acid effectively. So that leads up to kind of having a buildup of the lactic acid. It's not that it gets converted into that by any means. It just helps prevents the liver from really being able to process it and clear it effectively. And 2, if you have renal failure, that also leads to some issues in terms of clearing the lactic acid additionally. So that's where you can see some really severe wide anion gap metabolic acidosis that can develop from that. And again, specifically seeing elderly patients with renal failure on metformin, that's kind of the classic sort of case for that to occur there. Or after surgery, they got contrast dye and they got nephropathy, and no one realized that they were on metformin, they should take them off of it. That's kind of the cases you most often see that. I have a couple more minutes. I'll go over a few more classes here. Next, we have the alpha glucosidase inhibitors. This is going to be a minimally used set of drugs here because the side effects are going to be particularly not fun. We have acarbose and miglatol here, and these basically prevent the activity of alpha amylase and alpha glucosidase, which are enzymes in the GI tract that will normally break down sugars and allow them to be absorbed more easily. I'm not sure if they have any effect on fructose specifically, but I'm sure it might have some cross-reactivity there, which Shelby was asking about earlier. But basically, these will prevent glucose absorption. If the glucose molecules are too large, too complex, they're not able to be absorbed through the GI tract. So this is designed to block those enzymes and prevent them from having further glucose absorption, right? So this is good because you find that the drugs have pretty limited absorption. So this might be good for like, a pregnant patient who want to have limited exposure to a fetus. However, as you might imagine, what happens to all of those carbohydrates if you leave them in the GI tract? Well, they're going to get broken down by something. So it's probably going to be the bacteria in your gut. And I don't know if you guys are familiar with the process of like fermentation, but when you break down sugars, oftentimes you can develop things like CO2, and you'll get a lot of off gases. So you're going to find the GI side effects are going to be the main things that sort of limit patients' sort of compliance with this. But basically, you take it with the first bite of each meal, mainly because of the fact that you're using this when there is sugar in the GI tract that needs to be absorbed. So that's when you want to take the drug and actually block it. As I mentioned, may sometimes be used in combination with other oral agents, but honestly, you don't see a ton of use of this, mainly because you can see abdominal pain, you can see diarrhea, and you get a lot of flatulence, basically because all these undigested carbohydrates being broken down by colonic bacteria are going to lead to a lot of gas production. So flatulence is pretty common. So I said, well, this could be good for pregnant patients. Like, well, they probably already have a whole host of GI effects they're dealing with anyway. I don't know if I'd want to make that any worse for them as it turns out. So again, another one in the long list of why if you can get lifestyle modifications, if that's going to be possible by your patients, that's always going to be the best thing for them, right? Patients you'd want to avoid using these in would be those that have inflammatory bowel disease, GI obstruction, chronic intestinal disease. Any of those, this could just be worsened by just having more irritation and buildup of gas there in the tract. Matt was asking, can you use alpha glucosidase inhibitors as a weight loss supplement since you can't absorb sugar in a non-diabetic patient? I'm not aware of it ever being used there. Certainly, we've gone with the blocking absorption modality before. So there was a drug called, I believe, Ally was the brand name. I'm gonna find the. I haven't looked at it in quite some time here. Let me see what the generic was. It was Orlistat. That was the drug there, Orlistat. And basically it blocked the intestinal absorption of fats. And so, if you were to look at the caloric content of a gram of a carbohydrate versus a fat, it's 4 calories per gram of carbohydrates, 9 calories per gram of fat. That was actually used as an over-the-counter and prescription weight loss agent. They said, okay, we'll block the fats from being absorbed. You just poop them out, and then you're good to go. And that it can be effective for weight loss, but also think about the side effects there of having all those fats in your stool. Well, you get a lot of incontinence. They would always tell you, okay, you're gonna have these greasy, oily stools. Make sure they can stain your clothes, so make sure you bring extra pairs of dark pants with you. Like that was in the patient education. So not super ideal. I would say if you can maybe look for other means of weight loss, that might be good. I think metformin could be a reasonable option there, and you'll see a lot of patients, especially with PCOS, can actually be treated with metformin. So you might learn that from like Professor Lack in the OB-GYN section, but you'll see metformin can sometimes be useful for that. And again, a lot of patients or some patients with PCOS are overweight, and that metformin can actually help out with that. It can help to limit some of that to some degree there. So yeah, I'll talk about some other agents though that actually are much more effective for weight loss than the alpha glucosidase inhibitors, but that might have to wait until next time because I'm out of time currently. And this is a big topic, so I don't want to necessarily broach this currently unless I can kind of finish it up. So, do you all have any questions that I can answer for you? I don't see anything up here so far. Otherwise, if not, I appreciate you joining me here today. It was nice to talk to you guys. It's been like, what, 2 weeks? I don't like having these big breaks, but, I don't control the schedule. But, yeah, if you have any questions or anything, I'll stay on for a minute or two. And otherwise, you guys are go have a great day. Yeah. Yeah, thank you. And I'll see you here tomorrow at what time? 2:30? Yep, 2:30 tomorrow. Wait, I'm looking at the wrong week. Yep, 2:30 anyway tomorrow. Yep. Thank you, guys are awesome. I will see you all later.